2, 3.
Foundation, society, this broadcast, your camera and microphone has been disabled. You should submit your question to the panel using the question and answer box at the bottom of the broadcast window, not through the chat. If you have any technical issue, please close your browser and restart it, and the webinar perhaps move closer to your router. The Society will release a statement following the webinar, which will be a recommendation and conclusion of this meeting. You could follow the conference at the SAS, the Twitter account of the Society at SAS_KSA. So we'll start with our top topics. It's about the SAS protocols for COVID, best practicing guidelines and highlights, OB and pediatric anesthesia updates and highlights and recommendations, cardiac and thoracic anesthesia updates and highlights, neuro anesthesia updates and highlights, and finally the highlights on anesthesia specialty role in healthcare system. So our first topic will be the SAS protocol for COVID-19 best practice guidelines, moderated by Dr. Fahad Al-Qurashi, who's the Chief of Division of Anesthesia Critical Care at Johns Hopkins, Aramco Healthcare, and consultant of anesthesiologist. And also Dr. Abdullah Al-Harbi, he's a consultant anesthesiologist and Chief of Anesthesia Department at Saudi Security Force Hospital in Riyadh, Saudi Arabia. So I'll give the microphone to Dr. Fahad Al-Qurashi to start our first session. Dr. Fahad.
Thank you, Abdulaziz. Assalamu alaikum, colleague, and welcome again. And thank for the Saudi Anesthesia Society organizing this webinar to go over the guideline and the recommendation. So it is my honor and pleasure today to search the first session, which will be discussing the best practice guideline for COVID-19 done by or presented by Dr. Abdullah Al-Harbi. As Abdulaziz present him, he's our colleague, anesthesiologist consultant, and the chief of the Department of Anesthesia and Security Force in Riyadh. So we'll leave the mic with Abdullah and looking for his discussion and the presentation. Abdullah.
Assalamu alaikum wa rahmatullah. أسعد الله مساكم جميعا. Thank you very much, Dr. Fahad and Dr. Ijaz for the introduction, and thank you for the Saudi Anesthesia Society actually for this activity, which is actually a continuation to the great effort that we all have seen and in the previous conference. So this lecture, which is about to share the presentation. It's just a summary to the previous lecture that I've given, summarize the recommendation that been provided by the Saudi Anesthesia Society with regard to airway management. Been a great help to most of us in anesthesia practice, and it was actually well written, and it covered almost most of the anesthetic practice in different specialties. So what I'm going to add to this one, so this is a summary, but I'm also going to add at the end the recommendation from Saudi Anesthesia Society regarding resuming elective surgery, which is a topic that most anesthetists probably have some question about, or sometimes some concerns or So with regard to conflict of interest, nothing to declare with regarding to this lecture. And probably it's almost now aware of the COVID-19 and SARS, and there is no probably need to put any definition even in the community. So as we mentioned previously, the Saudi Anesthesia Society, they have done a great job actually during their special volume from the Saudi Journal of Anesthesia, actually writing the COVID-19 outbreak by Prof. Abdulaziz DrDawlatly and Prof. abdulmomen, and also the airway management protocols, which was led by our colleague Dr. Muhammad al-Harbi and his group. So the objectives were mainly to provide an update about the COVID-19. At that time, we're actually, as a clinician, we did not have a lot of trusted resources to give us a full full review actually of what has been published or what has been seen, even in other specialties. And it also to help the practicing anesthetists in giving them a guidelines with relation to airway management in patients with suspected or confirmed COVID-19. And they also did a great job in describing the recommended personal protective equipment suitable for airborne droplets and contact isolation. So they defined the suspected cases, the probable cases, confirmed cases, and contact, and according to the available evidence at that time. And the principles that they followed were purely focusing in preparation. So how can we prepare the personal protective equipment, and focusing on the time needed also for the donning and doffing process, and the role of observation. It's having an active observation, like with someone watching the colleague while they're donning or doffing. And this is all to maximize the safety. And they also mentioned the minimum number of staff, and also having a clear warning signs and proper plan or detailed plan for the airway management. So if we are suspecting difficult, or if the place that we are going to do the intubation is actually like in a remote area, or if we have any difficulties. So it's better to have a plan for the devices needed rather than actually rushing to intubate and then finding difficulties in the middle. They also emphasized in team dynamics, and these guidelines emphasize team dynamics, assigning the roles and getting the most expert clinician to lead, and the communication and cross-monitoring of for any contamination, which is just continuation to the observation also from the donning and doffing process. The environment, they also gave advice about the negative pressure rooms, dedicated areas, pathways, equipment disposal, and HME filters, HEPA filters, all these one. And the patient dispatch. So once we finish this patient going to ICU, going to a specific area. So for the environment, so they talk about the negative pressure room and dedicated airway, equipment disposal, and the ASA, American Society of Anesthesiologists and Anesthesiologists, standard monitoring. This is during the airway management. And they also mentioned that the expert airway management should be led by the most senior person. And one reason actually to minimize the time needed for the process of intubation, for the aerosolization process, and also for in case of any difficulty, minimizing the persons involved directly with this possible infection. And lowest possible gas flow to maintain a safe SpO2 rather than having higher flows, and also that will lead to more possible more spirit or more aerosolization. And if we can minimize the leak from the face mask, that was recommended, and to perform rapid sequence induction or modified rapid sequence induction if possible, using video laryngoscopy as a process actually to have the advantage of keeping the practitioner away from the patient, and also it will be one step ahead in terms of if you face a difficulty rather than having multiple attempts. And they advised against fiber optic intubation unless highly needed. and positive pressure ventilation to be delayed if possible until the cup is inflated, and that's also to all to minimize the process of aerosolization. Maintaining closed circuits and to avoid any unnecessary disconnections, and when disconnection of the circuit is needed, they advised about full PPEs and clamping the tube, and the ventilator should be on standby mode. So the disposal, reheating the laryngoscope immediately, and that's also to minimize the cross-contamination of other stuff or for even the practitioner. And it should be sealed, all the used equipment, and a double Ziploc plastic bag, and sent for decontamination and disinfection. So for the doffing itself, the strict adherence to proper doffing steps in terms of education, monitoring, and hand hygiene and cross-monitoring also. And for the PPE itself, so they mentioned the fitted N95 mask, and they emphasize on the process of having a properly fitted N95 and for the objective, and also the PAPRs or the purified devices. Goggles, footwear, waterproof gowns, and gloves should all be utilized when you're dealing with suspected or confirmed cases. So they also not stopped at that level. Actually, they went far, further in putting guidelines in dealing with pediatric patients with suspected or confirmed 19. And it was similar in the principle to the adult, but they emphasizes also, or the guidelines emphasizing IV induction if possible, and muscle relaxation to minimize coughing, and using microcuff endotracheal tubes should be used, and deep extubation. So if we can probably see, especially for most of us who don't do pediatric anesthesia on a routine cases, we can see probably some of these, not what we do normally. So most of the time we use inhalation induction if the child doesn't have an IV, and we prefer generally to extubate the child and awake. But in this situation, actually the aim is to protect also the staff and the healthcare worker. So all these measures should be actually implemented if possible. So thoracic surgery and lung isolation, there was also a detailed guidelines by Dr. DrDawlatly and Dr. Tahan and their group, and they mentioned, so if someone wanted for a reference, it was excellent in terms of lung isolation if possible, and using using even suction through the tube. And it also, there was a guidelines on ophthalmic surgery for patients with suspected or confirmed 19. So the good thing about these guidelines actually is very comprehensive to the anesthesia service. If you look at other international guidelines, probably they did not go into detail. So most of them focused on the airway management. I think they actually involve the ophthalmic and even electroconvulsive therapy, which I myself have been involved in a couple of cases with ECT during the pandemic, the peak, and it was helpful also to go back and just have some guidelines that actually assisted me in taking the decision. So ophthalmic surgery, there was nothing much about airway management per se, but we were talking about screening and the need for surgery, and similar for electroconvulsive therapy and using the mask. So for CPR, there was also Dr. Khan and his colleague, they also have written an update about the CPR, which is similar. They emphasize on the use of PPE and covering the victim nose and mouth with a piece of fabric, and the rest of the CPR as recommended internationally. So their final comment was about the process of preparation when dealing with airway management in a COVID-19 patient, and preparing the PPE, the environment, equipment, briefing the team with the roles and communication, and planning dispatch of the patient transfer process, and having a process of manage the staff and isolation also. So the new probably addition to this talk today is just resuming elective surgery. So probably a question that comes to us all the time: are we ready to go back to a full capacity for elective surgery? So the Saudi Anesthesia Society have published a statement about resuming elective surgery during COVID-19 pandemic era, and I can actually summarize it here. So why it has been published? Because we are aware now from the literature that actually people who are infected with SARS or the COVID-19, they carry higher perioperative morbidity and mortality. So there should be a sustained. So they started with the regional actually numbers. So there should be a sustained decline in the total number of cases during the COVID-19 for at least 14 days in that area in order to resume non-urgent surgery. And the availability of mass testing should be considered. So because if you are going to open for more elective patient, then you are likely going to more need testing for these patients, and also for the staff who actually get in touch with this patient. If you by chance develop or get exposure, if one of the patient or one of the staff get exposure or multiple staff get exposure to one patient that will tend to be a positive with this testing. So they recommend that PCR screening should be performed for all pediatric surgical patients as well as their guardians. And before we consider full capacity, we should always revise human power for anesthesia, for surgery, for nursing staff, because COVID-19 time has its tally on all the health sector. And also, if you go into full capacity, then there is a chance that for exposure it may happen. And on that one, say, if you discover by a chance one of the patients who had the surgery tested positive, and then all these staff who were exposed, so what are you going to do with them and with the booked cases in case that you isolate them? Definitely, they also mentioned the adequacy of PPE for anesthesia and for surgical supply. So before into full capacity, we should have adequate chain supply, and we are happy with that. Presence of vacant inpatient critical care beds. So that's also something we should consider before we go into capacity, because when we go into full elective capacity, some of these procedures, some of these patients might require the intensive care. And if this might affect the capacity of the intensive care, or we have a limited capacity, then we have to reconsider the decision of actually resuming the elective. We should have a planning for surgical pathway with reference to high-risk infection. It's either through a non-COVID patient or the healthcare worker. So if we are opening the elective cases, then there is a chance actually of getting one patient that who might be positive, and or even an emergency cases, and then the other patient who are doing the elective surgery. So how are we going to manage if there is a possible cross-infection, or if how can we stream actually or divide the patient during this peak capacity when we have a lot of patients coming in the morning and there is a chance of an emergency also who is positive. So it needs a lot of organization and consideration. Also, they mentioned the consent, so modifying the consent to include the statement on the risk of COVID-19. So given that we have already, we know that there is increased perioperative risk in terms of morbidity and mortality for someone with COVID. So the patients who are coming for non-urgent surgery should be aware that about this fact. It's either the possibility of infection during the hospital stay or catching it, and also the complication that might happen. So they can make an informed decision about the timing of the procedure. So they also classified the cases, and they recommended to prioritize the case to a non-time sensitive surgery, where in whom the postponement until 1 year will not have a negative impact on the patient outcome. And that's for the pure elective surgery. And on the other side, the time-sensitive surgery with a scheduled surgery for patient whom the delay more than 1 to 6 weeks potentially has a negative effect on a patient. And these are the surgeries that we probably should go ahead because weighing the risk and benefits. Okay. So the urgent surgery scheduled that must be done within 24 hours of the patient outcome. And this is definitely probably out of the question, and usually there is no issue with this type of surgery. So no doubt that the final decision should be also based on every institution and every regional area where they can take all these consideration into account, because it's not only related to anesthesia, let's say, or patient. So we have a long waiting list that is accumulating, and also if you open it, there is an increase also capacity or increase utilization of testing. So sometimes what's the capacity of my lab and what's the capacity of the center that if I have an outbreak during this one. So it's a lot of things that probably some of it relate to anesthesia and the rest is probably needs collaboration and also administrative input. So the recommendation, all selected patients should have a proper assessment triage tool looking for classic symptoms of COVID-19. So this is just a screening process, like if we have any symptoms, headache, as well as non-classic symptoms like loss of smell, diarrhea, any history of contact with a positive COVID-19 patient. For anyone who actually scored with a high risk with the screening test, non-urgent surgical procedures should be postponed for 14 days before reassignment. So you can see here they did not recommend for testing. So if it's a high risk with the screening, the surgery is not urgent, then they recommended just to postpone for 14 days, for 2 weeks. Low risk COVID with the screening with a negative contact history, then they advise to proceed for the surgical procedure, but should have the screening for the PCR testing. All scheduled patients to undergo non-urgent surgery have a COVID-19 PCR preparatively, and all non-urgent surgical procedure for patients with a positive COVID-19 test should be postponed until full recovery. So I think this is the main summary, okay, for the COVID-19 about resuming the surgery.
Thank you, Abdullah, for this excellent summary and presenting all the guidelines. Just to keep the time, I think we're going to move to the next session, and we're going to keep the question at the end of the webinar. So we'll hand the mic to our colleague Fatma for the second session. Dr. Fatma.
Okay, thank you, Dr. Fahad. And now we'll go to our second topic. It's about OB and pediatric anesthesia updates, highlight, and recommendation. Moderated by Dr. Fatma Dammas. She's an assistant professor and anesthesia consultant. Also, she's the head of pain management unit at King Saud University. Our speaker will be Dr. Nasser Tawfeq. He's a section head and consultant of obstetric anesthesia at National Guard Hospital in Riyadh. So, Dr. Fatma.
Good evening. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Welcome in SAS virtual conference highlighted and recommended webinar. Thank you, Dr. Abdulaziz, for these introductions. I would like to welcome all attendees in our session, and just to say that feel free to submit your scientific questions in a Q&A icon, as it will be discussed later. Please join me in welcoming Dr. Nasser, who is going to update us about obstetric and pediatric anesthesia. Enjoy the session. Dr. Nasser, mic is yours.
ان شاء الله يكون الفويس كويس. بعد التست كله نبدا. بسم الله الذي لا يضر مع اسمه شيء في الارض ولا في السماء. طبعا المشكله انه all our topics يعني shared together, and all these topics you're gonna may find some information. فكان مرة عندي مشكلة إنه what will be the news, so I will try to give you in a short time of 10 minutes what do we need to know about corona. Corona start to be an epidemic, but the problem is that it's just orientation of the situation, what's going on. These are our fellows who help us to prepare the lecture in obstetric anesthesia. I'm trying to advertise for our program. Okay, the bad news, guys. SARS is going rigid and will be more with health worker. So it's really a serious thing. Do we really worried about corona because of health worker? When we look at the study, we found that as a health worker, your incidence to have infection is higher by 7% than other. It means that every day you come to work, you have 7% chance that you're gonna get COVID. If you deal with obstetric, you're gonna have higher incidence. If you deal with pediatric, you have higher incidence. Our colleague before said we should cancel the cases. I can challenge you, who can cancel a C-section? I think it's really gonna be a difficult thing to be done. Okay, what's the result? They found that the COVID overall epidemic in healthcare worker is increasing, and being a health worker will increase your risk of having the infection. So why I brought this slide to give you this bad news. If you are a health worker working in obstetric and pediatric, any health worker, you need to really and listen to the recommendation of our colleague that it's not a game, it's a serious thing. Not that only, by the way, the hospital is pushed to change their system. We always talk that we have the best OR, we have no infection, because we think the infection comes from our hospital to the patient. Now we have to have a negative pressure room. The infection will come from the patient to upstairs. So this is a serious thing. Make hospital try to force and make the positive pressure, negative pressure room. With this simple introduction, I'm trying to alert you that the situation is serious more than before. Not that only, the corona in the last recent breaking news, it tells us that it changed its site from 23 site, meaning COVID-21, if we can call it, from 19 to 21, start to be more infectious, more serious. Then we come back to the basic. Guys, just try to no shaking, distance, and you try to think that every patient is infectious, still proven otherwise. Again, we always think that infection and prevention strategy is an important thing that we need to carry about. I'm just trying to remind you, the presence of HEPA filter will not prevent the infection. HEPA filter will make it more, because the circles of the air will be more 40 times. It means that the ideal thing is to have an OR with a negative pressure room. The ideal thing is to isolate the patient. The ideal thing in obstetric or pediatric to decrease the number of the people who's going into the room. So don't try to make more than one consultant go into the room, one person from each specialty, and even if he can be outside remotely will be better. Again, we need to have a managing strategy. Before this patient come to the OR, you need to have a good communication at the beginning. You need to inform the team that this patient and responsibility and coming to the hospital alerted by all the hospitals. So the nurses will operate in certain room. In our hospital, we dedicated one room for the patient to be operated if you have a corona or suspicion. And that strategical things need to be thought more and more. And the precaution should be taken for transferring the infection from the patient to another patient. One opening room should be dedicated for COVID. As we said, the patient enter and exit the OR should be limited. The visitor will be limited. You're gonna stay with the patient till he done his surgery, no break till you finish. All the precautions that we usually receive and do is really important to take in consideration. Why? Because it's not a game. Reduction of elective cases. This is a really serious decision. As we said beginning, and I was really scared when he told me that up to 1 year, we should make the patient delay surgery. If he get infected and he did an elective surgery, he have to wait 1 year. If he is not infected, I think if he come to our hospital or to any hospital, he may get corona, and we've seen that in our hospital. Not that only, now the OR management in obstetric or in pediatric, they will ask you to have a high rapid turnover. This is kind of mission impossible. No, it's gonna take longer. You may only do 2 or 3 cases. the cleaning precaution, the things that happen between cases is really getting more complex. You need to wait for 1 hour and a half. Do not use air hugger for the patient, because you can transmit the infection from the patient to the air. So things gonna change essentially in our obstetric update, because most of our patients or in pediatric have hypothermia during the OR. Now we have to think twice that we should make the room hot, not make the patient hot only, which make it very difficult for our surgeon, which I find it good so the surgeon can finish quickly. Again, we need high quality filters for our machine. Our machine can get and transmit the infection. So having a good department which follow the recommendation with regarding the filter and the breathing circuits is an issue. Okay, traffic, no traffic in the OR, making sure that we have enough number of N95. All these things is really important to really emphasize. Only essential equipment should be inside the OR, minimize number of necessary people in the OR. The operation setup have to be changed, as you know, in obstetric or in pediatric. It means that not all the medication you think and dream of will be inside the OR. Life start to be different now. You're gonna know what you need. In obstetric, maybe you are lucky because you're gonna do spinal. No, you are not lucky. Just wait. You're gonna know more. Again, endorsement team. Again, on timeout is really important to understand the circumstances of the corona. You may have, I have to highlight that the problem with, as our speaker said, you cannot tell if this patient 100% corona, because the corona will stay for at least 7, 8, 10 weeks. It doesn't mean that he shed the virus, but he may tested positive. So you have to treat him like a criminal, and you have to continue treat him like a corona, which make it more difficult for you to work under all these goggle and mask and to think that you can do a better job. Again, exposure and spread, we have to think about our agent. What should we use in our induction agent? Should we modify them? Still, we have the propofol gonna be still the use, the muscle relaxant, the Sax or the rocronium or whatever you have is still valid. The anticholinergic medication, you're gonna bring it with you to reverse the patient. Antiemetic, there is no problem with them. The analgesic, the only thing we worried about the analgesic is the data which came about brufen and so on. So you cannot give ibuprofen or NSAID because it get the infection worse, but most of our medication will be fine. We will have a challenge with the spinal anesthesia because we don't know if our intrathecal morphine given is good or not. Yes, it's good. The problem, the CCF coming from the corona patient still can be infectious. Some data show us that be careful about the fluid of the patient. And not that only when they deliver the baby, that you may expose yourself to the blood of the patient. A question for thought, do you think patient who transfer and give a blood transfusion, he's corona positive and he doesn't know the corona will transfer to your patient? So when you deal with blood, you cannot tell if the blood you give to the patient is free of corona. I know people will say, what are you talking about? The studies show that the corona can transmit through the blood. We don't have a test for the blood to test if the blood test have a corona. We know that it have HIV, it have hepatitis A and B and C, but corona, we are not there yet. So handling the blood can get you risk of having corona, or even the patient can transmit corona. That make us more conservative in corona time with obstetric and pediatric. Anesthesia induction, not much of a change. I want to finish my 10 minutes because I'm sure that we have a lot of questions to run around. So these things is really advanced, not that only when we get these people sick, they need an ICU, and with pediatric, tell me if I can do MRI for him and take him to the MRI to have rule things. So I'm again saying to our colleague, if you please don't need MRI, don't make me put corona patient under anesthesia. It's a risk for everybody. And I don't think confirming the diagnosis or confirming the status of the lung will help a lot. So be careful. You may do urgent anesthesia for them and so on. And remote anesthesia maybe make it more complex with these things. Okay, post-operative anesthesia, Again, we have a problem with the nurses now. They are so scared that they're gonna deal with a corona patient, and even the patient is scared from the nurses because they look scary. So the equipment and the things that you care about and the room and the infection that you have in the room need to be really studied by everybody. Equipment and supply gonna be new. You may your hospital have no enough supply, but recall and remind them that the area of recovery room need the supply all the time. Anesthesia supply if the patient deteriorated. Again, the isolation room, most of recovery room have no isolation room. Some only of anesthesia recovery room have isolation room, and that make our things more complicated. It means that you may need to recover the patient inside the OR, and run the show in the OR will be really difficult, and block it for more than 4 or 5 hours for one patient. So if you don't have isolation, it means that most of care strategy gonna be compromised and the patient gonna be compromised. Again, management of healthcare worker after caring of the infected patient. You always have a depression after you deal with this patient. Let's face this situation. You think you're going to be infectious. I know some of our colleagues even take a separate room in a hotel because he worried to transmit the infection to their lover and their family. So he think that staying at this place will prevent him, but he forget that the person who cleaned that place even can get infected. We make the problem with the people who have a healthcare worker like us having more serious. Thanks, we don't know if we have corona or not yet. We think that we did not get it, but maybe on the timeline we get it and it went past. Obstetric anesthesia recommendation is like the pediatric. You know, the pediatric, I want just to remind everybody, when you deal with the pediatric, you deal with a mother which you don't know if she's corona positive or not. She tested negative, but she's with the pediatric for a long time. Again, when you deal with obstetric, I don't have much recommendation, but I will try to pass by if Fatma did not stop me. Again, the screening, do we trust the screening? We don't know. The mother who's trying to socialize with everybody and visit her everybody to congratulate her for her pregnancy come to you, and she did not know that she's symptomatic. Unfortunately, during the COVID time, 30% of our obstetric ladies have a COVID. 50% of this 30% doesn't know that they have a COVID and they are asymptomatic, which make us screen every patient who's coming for obstetrics. So our recommendation that any woman come with symptomatic, regardless symptomatic or not, have to be tested, because the pregnant woman will not show it because of the high surge of the steroid that they have. Understand COVID, you have 25% of a chance that even if your test is negative, you are positive. If you repeat it, this 25% goes to 12.5. If you repeat it, it goes down to less than 6 if you repeat it. So it needs that you repeat it 4 times to know that this person have no COVID. It means that we lost the confidence in our test and we worried about every patient. Not that only, the pregnant woman never stay in her bed. She want to socialize with other pregnant women, and she may infect other or get infection from other people in the hospital. Real time, the goal of the COVID testing is just to identify as much as we can. Again, clinical management and PPE is more easier with the C-section because we insist that we're going to do spinal in them. We insist to cover their faces with N95. We insist to keep them in a different room, so we are less likely to get it. But I think in pediatric, you can get it easily. And what I couldn't find, that who is the healthcare worker gonna have more infection than others. What we found in our obstetric division, that we have 50% of the obstetrician have a corona already. Again, remember, the corona does not transmit only by respiratory conduct, as well as transmitted by fluid. It means that when they rupture any fluid, it comes to their face, so they have higher chance of developing it. So socializing with your colleague in obstetric is not recommended. Now, we think isolation room is must. We know the mask of the patient is important. The visitor have to be restricted. Our life after corona will be different. Just for the time constraint, I would like to remind about the case series about there is an incidence of thrombocytopenia. Be careful that your corona patient may have a platelet disorder that will make it difficult for you to do spinal. So look for it. Again, no ibuprofen for them, which you used to give as a alternative intrathecal morphine, as well the minimized exposure during urgent things by avoiding the intubation in obstetric. Guys, I really enjoyed the topic, but I have 10 minutes. Otherwise, Dr. Fatma will give us hard time. Thank you very much.
Thank you very much. Shall we go for a question now, or shall we wait till the end of all of the session?
Still have 3 minutes for questions.
Okay.
One question.
We have one question. They ask about when elective surgery will be done for people who got the COVID vaccine.
I think Dr. Abdullah answered it and said up to 1 year. Thank you, Dr. Abdullah. You cancel all, as a chairman, I think it's a very difficult decision. And I think it's taking case by case and so on, if it's a malignant or not malignant. So I think these decisions have to be done like a committee. And I think that COVID will last for the next 6 months or 9 months, even if we have 0 cases, because we think that even the tests that they announce cannot really detect all the people who have corona as we think. But I will give Dr. Abdullah a chance to answer.
Thank you, Dr. Daghestani. I agree. I think if the non-elective surgery, so the elective surgery, there is always a recommendation. I'm talking from an anesthetic perspective. If we can postpone, then that's what's recommended. But sometimes the other factors also play a role. But for vaccination itself, so I'm not aware of any guidelines per se, and I think it's quite early to have it. But probably the other principles that we apply in vaccinations. So sometimes, I mean, in the other vaccination, they classify it to the like live attenuated and non-live vaccines. But in general, probably they're talking about a 1 week period. I think the reason is not safety per se, but most of the time they're talking about actually the picture that might happen after the vaccination. So if a patient takes the vaccine and then goes to surgery and next day develops a fever, it just makes it sometimes challenging for the clinician. Is it actually an infection after the surgery or as a side effect? So I don't have a solid answer, but I think it's just probably as safe to say 1 week if the patient is actually insisting on the surgery and there are other factors that actually push toward doing that elective surgery.
Thank you, Dr. Abdullah, for this great answer. We have another question. Is it ethical to force the patient for spinal anesthesia if he is emergency and COVID positive?
Is it ethical to infect me? Simple. So who is the physician, you or me? The physician is me. So I decided the best thing for you is to have a spinal anesthesia. So I'm not sure why a corona patient wants me to go and dive in his lung where it is full of bugs or full of viruses because he doesn't like to see me or to see the baby or to see the situation. I think the choice of the physician, if you look at the incidence of spinal anesthesia in Canada, is 99.9%. In Saudi Arabia, we give them the choice. And this have to come back, as Dr. Daghestani, remember, everybody remember that, they have to come to the education. If the people try to use the fine line between line that it's contraindicated to do spinal for a patient refusal, I think we need, as Dr. Abdullah said, we need to revise and put a rigid guideline so people will not play with us and say that, no, it's my right to have a GA. It's like, it's my right to take a car 1970 to drive it for the next 1,000 kilo because I want the 1970 car. No, it's not your right to break every 1 minute and 2 minutes and to spread infection and to kill yourself. So Pat Sullivan, I will never forget when he say, a patient sued me better than a family sued me. So make the patient sued me because I bought a spinal better than the family come to sue me because I kill him because he have a corona and I could not make him go through the surgery.
Okay, thank you, Dr. Nasser. Before we go to our next topic, I just want to remind the audience that for the CME hours, for the people who register with the Saudi Council number, it will be delivered automatically to their account after 2 to 3 weeks from this session. So for our next topic, it will be about the cardiac and thoracic anesthesia updates and highlights, moderated by Prof. Abdulaziz DrDawlatly. He is a professor of anesthesia at the Department of Anesthesia College of Medicine at King Saud University. With our speaker, Dr. Dr Daghestani, he's a senior consultant anesthesiologist. So Prof. Dawlatly, the mic is yours.
Assalamu alaikum. Thank you very much, Dr. Abdulaziz, for this opportunity. And I also would like to thank the Saudi Anesthesia Society for giving me this opportunity to share tonight with you this interesting topic. The speaker for tonight is Dr. Muhammad Daghestani. Dr. Daghestani is a senior consultant anesthesiologist in Thoracic Regional Acute Pain Service in the private sector. He is course director, disaster management and emergency preparedness, American College of Surgery. He is instructor, simulation training affiliated with King Abdulaziz University, examiner in the final clinical examination of anesthesia intensive care in Saudi board. Always Dr. Daghestani is surprising me by his lectures. I am sure you will learn a lot from him tonight. And also he is surprising me by the background he is creating for his presentations, which at one time I'll be happy to learn how he is doing it. Dr. Daghestani, please, the mic is yours.
Thank you, Prof. Dawlatly, and good evening, everybody. First, I would like to thank you for the presentation, very kind of you. And I would like to thank the Saudi Anesthesia Society for bringing up this activity back online, so we could share expertise and we could share thoughts and information together with our colleagues in different regions and across the kingdom. I'm gonna share my screen with everyone so that we could actually go to the presentation. So as a disclosure statement, I do not have any affiliation with any commercial organization that may or may not directly have connection to my initiative and content of this presentation. I'm just being invited to present this talk about update in thoracic anesthesia in the era of COVID. So moving along, everybody remember this picture in the news when it came up initially, which shows the World Health Organization declaring the COVID-19 pandemic, and at the same time, this declaration have changed dramatically the way we look at things in our region and in our society in terms to practice. Now, I'm just wanna carry on. Here we go. Sorry about that. Now, carrying on, everybody again remembers the history. These are pictures of the differences that have occurred in the world, including our holy city of Mecca. Nobody ever have thought that at any time the Haram and Kaaba would look very empty like that. And I hope things go back to normal one day, inshallah. Now, again, from the history, the 14th International Saudi meeting was conducted as a virtual conference compared to the 13th. 13th, we attended physically. It was a nice gathering. We exchanged thoughts and discussion. Hopefully things will get back and truly we get back to physically, talk together. Now, let us move to the topic itself, and let me just start by a few points related to thoracic anesthesia. Commonly, we used to teach classically thoracic anesthesia in terms of airway management, tools used for lung isolation. We classically use the normal physiology as our guidelines between awake and anesthetized, the differences between the lateral position, the blood shunting, and compared to the changes that happens with one lung compares to two lungs. Now, things have changed. Right now, situation is completely different. We have a new pathophysiology that is happening, affecting the whole information we know in relation to lung physiology. The airway management tools and control became a bit challenging because now with the use of preventive devices and the shields and the masks and everything, so it became a bit challenging to properly visualize the airway. The principles that we know about thoracic anesthesia have changed dramatically because now the physiology and pathophysiology of hypoxia is different from what everybody used to know. The tools and equipments have evolved. There is more emerging tools in video laryngoscopy and videoscopes and bronchoscopes. And still, despite the knowledge we have, I still believe, and everybody have noticed, that our knowledge in the field of COVID still lagging behind. The research is still under development. We are still truly being updated every now and then with different information. So what do we know in reality? Now, when I wanted to search and I came across a lot of publications, surprisingly very fresh, year 2020, in the field of thoracic anesthesia, because this have caught worldwide attention. So everywhere you go, just put the keywords COVID-19 and put any relationship to it, you will have a very fresh, out of the editor's list, references. Now, that doesn't mean that references is good, because in reality, some of them are just repeating some known information. Some are very, very unique based on very strong evidence in the field. Some have gathered by truly experts in the field who have gathered around and issued a consensus of how, such a process for different fields in anesthesiology should be conducted based on experts in the field and general guidelines, combining together and putting it to maximize the benefits for our practitioners. So if I want to talk about the pathogenesis of SARS and COVID-2, and we know that this is a respiratory disease, so the target organ is going to be the lung. Anybody who's practicing thoracic anesthesia, he knows that your whole game depends on healthy lungs. Well, when you have COVID, that's not a healthy lung at all. You already have a messed up lung that a lot of things have happened in there. We do know that COVID does affect other organs like the nose and the mouth and the mucosal structures. It does have some effects on the sensory nerves, on the olfactory mucosa, causing some drop in ability to perceive smell, different symptoms in relation to temperature regulation in terms of fever and so on. But let's concentrate on the lungs and let's focus about exactly what happens in there. Now, we know from evidence and from review of certain experts in the field of COVID, there is an alveolar damage that occurs. And secondary to that alveolar damage, hypoxia subsequently happens. That hypoxia sometimes go to the extent of causing hypoxic respiratory failure which is usually a fatality in many patients. Not only that, but we as well know that there is a dissemination of a huge amount of cytokines and release of inflammatory reactions that happens at the endothelial level, causing a basement membrane injury and causing disruption at that cellular level, which will cause two things: cytokine storm and activation of the coagulation pathway, leading to microemboli and thrombi, which in turn can lead to stroke or embolism. The cytokine storm, because of the massive release of those aggressive mediators in the human body, it might lead to a shock, which we know as ARDS, or multi-organ systemic failure, is a common name, but its reality is a bit different in pathophysiology. And a lot in the field have learned that use of steroids does decrease those inflammatory reaction and massive cytokine storm to decrease the injury effects on the human body. Now, let me move further. Anesthesiology have published, an article back in October year 2020 describing the pathophysiology at the alveolar level. So when the virus gets inhaled through the alveoli, it goes down in the lungs. And in the lungs, we have the type 1 and type 2 alveolar epithelial cells. These cells get activated, so the angiotensin converting enzyme receptors get activated with the molecules from the alveoli, the spikes of protein on the surface of the virus, leading to a massive reaction that involves the basement membrane, causing disruption and injury at the level, causing some leakage of blood, causing thrombi and edema, and flooding of the alveolar with fluids, leading to hypoxia. And pulmonary edema is a reflection. When you subject the patient to a chest X-ray, you have a massive inflammatory reaction that happens in the lungs, and commonly the lungs have been described as, flooded or wet lungs, or a massive, inflammatory reaction that affects both lung bilaterally. Now, let me move across and look at the acute respiratory distress syndrome and the management that happened across the years. Since the year of 1995 until the year 2020, several trials have been published in the literature. Some of them have been shown to be of benefits. Some, kind of not truly very effective. And if we look at it, the red line here, intervention shown to cause potential harm. So we know that the heavy dose methylprednisolone and omega-3 and the rovastatin trial was not truly of any benefits on those patients. Now, up ahead, we have intervention that likely have no clinical benefits, or it has mixed or intermediate results. And you could see the dexamethasone is among that group. So not truly, we could judge and say it is not effective, but it's questionable now. Every pathophysiology of diseases are different. We know in COVID patients, some patients who received dexamethasone, the response were variable. And some of them, there was a drop and a decrease in the acuteness of the inflammatory reaction. Some of them were saved even the need to intubate and mechanically ventilate and support their respiratory pattern. Just to have a look on the top line, and we could see the prone position. And everybody who worked in intensive care unit in the last month since the pandemic and since March, we know that prone position was very useful in those patients. It is labor intensive for sure. It does require a lot of manpower. It is very exhausting. On top of that, remember, everybody is wearing his personal protective equipments. So it is very, very labor intensive and it is very difficult. It does have, and it shows benefits in oxygenation, and that's why it might be one of the tools and utilities that have been used try to optimize oxygenation in those patients. Now, let us look at this graph here, and we are talking about, oxygenation and the hypoxic ventilatory response. Now, classically, we've been teaching that the hypoxic ventilatory response do kick in whenever hypoxia starts to happen in the human body. It's a normal trigger by the carotid chemoreceptors due to the decreased oxygen saturation in the blood. That mechanism is modulated centrally, and it affects the shunting of the blood from areas that are not perfused to areas that are perfused. So we have an effect that does affect the VQ matching part, try to optimize the VQ matching part, and in turns, it does improve the hypoxic effects on the body. Surprisingly, in COVID patients, it was noticeable that a lot of patients, though they have developed low level of oxygen saturation, but their response did not trigger those compensatory mechanisms. And some of them, they even developed a sort of an adaptation part that actually does accept and no physiologic changes in the pulmonary dynamics and the respiratory pattern to equate the level of hypoxia that happens in those patients. Some have looked into this in deeper look, and they started to try to simulate physiologic response that's related to high altitude versus hypoxia from COVID. And they saw a lot of similarities between those conditions. Not only that, but they went even further into aviation medicine. And they started to look into the literature, and they started to look into the process that happens in aviation industry at high altitude when the oxygen partial pressure is low and hypoxia occurs. What is the human response to that? We know that as a compensatory mechanism, usually you start to develop the hypoxic response together with hypercarbia, and hypercarbia will stimulate the release and decrease the affinity of the oxygen hemoglobin dissociation curve, and it's going to shift that curve towards the right side. So there is less affinity for oxygen to catch the hemoglobin to catch oxygen, and oxygen will be released more towards the tissues. Now, in COVID patients, that kind of undergo an adaptation phase because there is a noticeable hypocapnia, not hypercarbia, but hypocapnia that occurs. And that is one of the things that have been observed. Because of that, the usual response to hypoxic ventilatory response and the dyspnea perception and the tachypnea that accompanies normal hypoxia with respiratory failure does not occur. And that explains why that some of those COVID patients, when their oxygen saturation at room air is 80 or 85%, or sometimes down to the 80, they do not show any pattern of distress except very late. At that moment of time, the dramatic crash is precipitous that those patients have no room of compensation, and that's why they go very quickly into crash and collapse because of hypoxia. Now, let's talk again. What do we know about COVID-19?
Sorry to interrupt you, because for the time constraints and to keep it on time, 5 minutes you have more, please.
Absolutely. Now, I'm glad, because that was the main theme, and this is what I wanted to highlight physiological wise. Now, what do we know from our scientific knowledge in about COVID, it is an aerosol generating, medical procedure. That's for thoracic. We know that we need to deflate the lung. We need to do lung isolation techniques, which does carry a high risk for SARS and COVID-2 transmission in the atmosphere. We know that the OR are positive pressure rooms. Already Dr. Nasser have talked about it. So we need to make sure that all anesthesia team wear the full PPE protection on those patients, and disposable tools should be used for intubation. I'm gonna quickly run through these slides so you know that those protective PPE is not the easiest at all when you're using it inside the OR. Positive filters everywhere to protect our machine, to protect the patients, to protect the staff. This is very crucial, very important. And if you notice in these pictures, we do even put filters at the site where the lung is going to be deflated. Another picture will highlight that very clearly. And as you can see, we put filters everywhere as the arrows show so that we can protect ourselves and patients. Again, the same thing, we need to protect everyone around us, and by applying those filters. If you're using the bronchial blockers, you apply the same tools. Disposable fiber optic scopes are available, so after the procedure or during procedure, you could use that and you could get rid of that. Now, this is an algorithm that is available. I recommend everybody to look at it. It is at the European Society of Thoracic Anesthesia. They have published this algorithm. It is very clear. You could just follow the pathway. It shows you how you should deal with patients when you want to deal with thoracic anesthesia. And with that, I come to an end. Thank you very much, Prof. And I would like to leave more room for discussion and questions.
Thank you very much, Dr. Mohammed. And I think, Dr. Abdulaziz, shall we take questions, or will, what do you think?
No, we'll go to the, inshallah, to the next subject.
Okay.
Then we'll take the question at the end, inshallah. Our next subject is regarding neuroanesthesia update and highlights, moderated by Dr. Ma'an Qattan. He's the Chief of Anesthesia at King Abdulaziz Medical City in Jeddah. And our speaker is Dr. Rizq Al-Amri. He's a neuroanesthesia and pain management consultant, East Jeddah Hospital. So welcome both, and Dr. Ma'an.
Thank you, Dr. Abdulaziz. I would like to thank, first of all, the Society for arranging this webinar. Second of all, I think in the next 20 minutes, Dr. Rizq Al-Amri is going to talk about neuroanesthesia updates. He's, as you said, a neuroanesthetist and a pain management consultant in East Jeddah Hospital. He did his training initially did the Saudi board, and then eventually had a couple of fellowships in University of Western London, Ontario, and as well as McMaster in Hamilton in Canada in pain management and neuroanesthesia. And without further ado, he's going to talk about mainly the perioperative stroke and the management related to anesthesia. Fadal, Dr. Rizq.
Okay, thank you, Dr. Ma'an, for your nice presentation. I would like to thank the organizing committee. Also, I would like to thank Dr. Abdulaziz and Prof. Ahmed for inviting me. So I will go through the slides. I will share it now. Okay, slides are shared now. Okay. So our talk tonight is about neuroanesthesia update. So first of all, I disclose that there is nothing, no conflict of interest throughout my slides. So we're going to concentrate on this update regarding the preoperative stroke. So I'll try to avoid the talk about COVID-19 and was really interested lectures throughout we heard tonight. So preoperative stroke is one of the main topics that have new updates in neuroanesthesia, and through this presentation we'll go over a view, literature review, and current recommendation. So as we know, stroke has found that it is the second leading of mortality in patients. It's about 16% of death, causing a lot of disabilities in general among neurological disorders and leading to also disability for life, accounting for 40 up to 42 disability related to life. So when we talk about perioperative stroke, we need to understand that it is the infarction or the ischemic or hemorrhagic stroke that happens during the surgery or within or after 30 days of the surgery. So stroke has been known that is catastrophic. It has been associated with mainly undergoing for the non-cardiac non-neurological surgery associated with 8-fold increase of mortality. Unlike a stroke in community setting, the mechanism of stroke in the preoperative time is discovered and associated with highly predictable origin, which is the surgery. So patient is going to the surgery and then the patient develop a stroke. So given the fact that surgery and anesthesia associated with increased stroke comparing to non-surgical group. And we know that the preoperative recommendation could minimize the risk of stroke. So we know through the time that even with our colleague from the cardiac anesthesia, that the study of stroke within the cardiac surgery, especially those surgeries that interfere with the heart and intracardiac surgeries associated with increase of the post-operative stroke. But if we go to the risk factors, and we know that there is predisposing comorbidities and perioperative events that is associated with the risk of stroke. So and add to that the high risk of surgery, especially vascular and non-vascular and cardiac surgery. So this is an overall incidence of preoperative stroke throughout the different age group. As we see, it has been studied from early life till the up to 100 years. As we see, the incidence of the non-cardiac surgeries are increasing with the time. So whenever you have an aging patient going to the surgery, the non-cardiac, non-vascular surgeries are getting higher incidence of stroke in each group. While the early age group is associated mainly with transplant, neurosurgery, and cardiovascular surgeries. So the awareness of stroke and the preoperative for patients are for non-cardiac, non-vascular surgeries are started in 2009, where the a review of around 371,000 patients. These files or these patients, we found only a 1,600 patients associated with a stroke. So the issue is are we detecting appropriately the preoperative stroke, or we have more, or this is this similar number that we have it. That led to a trial that was started in 2013. They call it a Eurovision Trial. And the Eurovision Trial was actually a prospective cohort study that done within 12 academic centers. And it was targeting to study at 65-year-old patient or older that going for inpatient elective non-cardiac surgery. And they had brain MRI after surgery. So there was 2 independent neuroradiologist experts masked the clinical data associated with that. They studied the MRI for acute brain infarction, and they are leading to diagnosing the stroke that are seen in the MRI. So the primary outcome cognitive decline. So any patient that they have change in their cognitive, they are included in the trial, and they use the Montreal Cognitive Assessment as part of this trial. So the interesting factors that the study was early published in 2016 that they found 10% of patients that they are including in the study, they have covert stroke. The covert stroke is an acute cerebral ischemia, even that is not clinically apparent. So the patient will have cognitive decline, motor impairment, which can lead to dependence and death. And this is the pictures of the MRIs that has been shown in the patient that they have changes in their neuro and their cognitive post-operatively, and they found that there was a covert stroke. So their finding actually was they published a trial in 2019, and that they found 1,114 participants, including the study. They found 78 patients that they have a perioperative stroke, which is going to about 7%. So among those patients they studied, they found that there is a cognitive decline 1 year after the surgery in those patients, which is the 78, around 42%. And this is lead to more interpretation. And they found that there is a 1 in 14 patient age of 65 or older, they have covert stroke. So what are the current guidelines for this? So the timing of the surgery after stroke is very important. If the patient have had stroke within the 3-month pre-operatively, the advice is strong not to proceed with elective surgery, and you should stabilize the patient up to 9 months. So the consideration of delaying the patient up to 9 months is class 2A. Also, if the patient is an anticoagulant, that we need to stop vitamin K, like warfarin, medication 5 days preoperatively, class A. If the patient is having a higher incidence of cardiovascular insult, that we need to go with bridging for those kind of patients. We need to stop anticoagulation 1 to 3 days preoperatively, resume it 1 to 3 days postoperatively, and the decision should be clinically related for every patient. So we need to study every patient and to see whether the patient is indicated to proceed with the bridging or not. So if the patient is anti-beta blockers, so the evidence is against beta blocker initiation at the time of the surgery. So whenever you have patient is already in the beta blocker and the statin, please continue it, but do not start the patient in beta blocker at the day of the surgery. So intraoperatively, the comparison between general anesthesia and neuroaxial, we had 3 studies looked to the incidence of stroke at the level of the patients that are going to the general surgery versus neuroaxial, and they found that in 2 studies that there was no changes or there's no statistically significant difference in stroke. But in the last study, we see that they had there was an increased incidence of stroke on the patient that are going for the general through general anesthesia. And they found that it's more related that the patient in those groups that are going to the orthopedic hip and knee surgery, that they are usually higher in their age or they're older. So inhalation versus TIVA, actually there is no difference in stroke comparing volatile to the non or the TIVA patients, and so you can you can proceed with any of these if the patient are indicated to do general anesthesia. So nitrous oxide, as we know from the basic science, that there is association with plasma homocysteine concentration that leading to impaired into endothelial functions, which is theoretically increase the incidence of cardiovascular incidence, and also related to tissue plasminogen activators, which is leading to increased hemorrhagic complications. So in Enigma's 2 trial, that they found there is no associations between nitrous oxide and intraoperative and post-operative stroke incidence in both patients that they have nitrous oxide. Recommendations for patients that are going for the elective surgeries. So you need to go with regional anesthesia if indicated, if applicable. If not, you cannot go with the regional anesthesia. You cannot. So the aim of regional anesthesia is actually to monitor the patient. So whenever the patient is awake, you could evaluate him neurologically. If not, you can proceed with general anesthesia. So both the TIVA inhalation can be used without any problem, and nitrous oxide is safe across the surgical populations. So what is the recommendation of blood pressure measurement? So the aim of it, you need to maintain the patient adequate perfusion and blood pressure from his baseline. So the incidence that you need to go with reducing the stroke on those patients that associated with hypertension. So whenever you have hypertension, please treat it. And the recommendation is also whenever you have a patient going for elective surgery like shoulder surgery that you're going to use beach chair position, please try to avoid prolonged hypertension without any monitoring for cerebral perfusion. So what about the respiratory physiology? The recommendation is to go with normocapnia. So we know that hypercapnia will going to increase the cerebral perfusion. On the other hand, hypocapnia will lead to decrease the cerebral perfusion. So please, if you could, keep the patient normocapnic in those patients that they have higher risk of cerebrovascular compromising. So in the patient that they have or they are bleeding, they have higher risk of stroke, as we mentioned from earlier. Keep the patient hemoglobin above 9, and this will lead to avoiding the complication related to that. So this is a recommendation that we need to go through. So what about the blood sugar management? Avoid tight control. So please keep the blood sugars between 130 to 180. And whenever it's higher than that, you need to treat it. Don't target lower blood sugar. Intraoperative beta blockers, as the current evidence is that metoprolol is associated with preoperative stroke. So if you have patients that indicated to give beta blockers, we should avoid giving metoprolol. We should think about short acting like esmolol or other beta blockers that has both either beta and alpha associations.
5 minutes, doctor.
Okay, and the post-operative guidelines. So the assessment of stroke is very important. So whenever you have a patient that is at high risk of stroke, go vigilance regarding the assessment and proceed with it whenever you have. So acute interventions is very important. That if the patient is diagnosed with stroke, we should initiate the multidisciplinary approach and to reduce the complication related to it. If you have patients that they have or they developed signs, symptoms of stroke, please proceed with imaging. CT should be done for those patients. Baseline ECG is very important. If the patient is at risk of vascular insult, stroke, we need to keep those patients in cardiac telemetry within the first 24 hours of the incidence. So whenever we have patient with high blood pressure, need to treat it, especially for whenever it's above 180, even if those patient has a sign of symptoms of stroke. This is also the aspirin could be used within the 24-48 hours. It's highly recommended. And the aspirin should be delayed until the last 24-hour patient that they have IV alteplase. And also we need to keep saturation above 94. As we mentioned earlier, intraoperatively, proceed with euglycemia with a target of 140 to 180 milligram per deciliter. So this is a recent publication of neurosurgical Journal of Neurosurgical Anesthesia. I couldn't adopt it because it's published 2 days ago. So I would recommend neuro or non-frequent neuroanesthesiologist or general anesthesiologist that doing neurosurgery to go through it. They mention a lot of things related to the current evidence, and also I'm happy to share it whenever we through my email. It also mentioned the current neurological symptoms associated with COVID that might be masking the other neurological symptoms. Thank you very much.
Thank you, Dr. Rizk. We'll move on to the next session, I think, and we'll receive the questions at the end of the webinar.
So our next session, inshallah, it's the highlights of anesthesia specialty role in healthcare system in Saudi Arabia, moderated by Prof. Ahmad abdulmomen. He's a professor and consultant in anesthesia and critical care medicine, and also he's the president of the society. Also, speaker Dr. Muhammad al-Harbi, he's the chairman and consultant of Department of Anesthesia at King and National Guard Hospital. Also, he's the head of the scientific committee in the society. So, Prof. Ahmed, the mic is yours.
بسم الله الرحمن الرحيم والحمد لله العالمين وأصلي وأسلم على رسول الله وعلى آله وصحبه أجمعين. Thank you, Dr. Abdulaziz, and thank you for all our moderators and speakers for tonight for the rich information that they are giving us. And actually, we're gonna our last session, we're gonna talk about the anesthesia role during pandemic. Of course, we're gonna start first with Dr. Muhammad al-Harbi, and then I will continue after Dr. Muhammad. Dr. Muhammad, please.
Thank you, Prof. Ahmed. Thank you, Prof. Ahmed. I think we are really happy to hear all of these great lectures done by our colleagues. What we will really close this webinar is by the two things that are really important in the practice of anesthesiologists, especially during the pandemic. I think everybody already heard all the information that has been generated for all the role of Saudi Anesthesia Society, providing all the guidelines and the practice change that has really developed over a short period of time. And that was the most important part that we have. Dr. Ahmed, can you just move to the second slide?
Sure, yes.
Can you, yeah, okay. So the anesthesiologists are really important in any institution. Next slide.
Okay. You see it?
Yeah. Why?
Dr. Muhammad, do you want to share your presentation, or shall I stop sharing now?
Yeah. No, you can start sharing, please.
Okay, sure. It's already sharing. Yeah, go ahead.
So the role of anesthesiologists are really important. Why the anesthesiologists are important in any institution? I think very clear. The anesthesiologists are very knowledgeable. They have a great background of medical and also surgical or perioperative information. Those are really giving you a combination of an excellent and confidence in the patient care. The second part is that typically are the skillful. They are combined of an excellent skills combined with the knowledge. It will really generate the ideal or a physician who can manage a critical patients. They are also leaders by their character. In the operating room, the anesthesiologists are the most important leader, taking care of the patient. Also in any things that related to patient care or other physician, he is the one leading the care. Also, they are available all the time. Rarely you will find any operating room running without an anesthesiologist. And that's what you really have. And the anesthesiologist is always available day and night. We'll move to the next slide. During pandemic, it's very clear. The role has been developed very well based on, of course, caring for emergency and urgent cases like a cancer patient, also airway governance. They are the most expert, and I will not really repeat what most of our colleagues they mentioned before. And also the expanding role of the anesthesiologist to cover the intensive care unit and opening a new area to meet the demand on the patient for COVID cases. Also developing a rapid response team. This has been really a major role, and we'll discuss it in the next few slides. Next, for the emergency and urgent cases, as you know, by its nature, those cases has to really run. Most of the anesthesiologists are the frontliner in the perioperative care. They usually, during the pandemic, all the cases are really continuous. Any institution, they do have their emergency room running all the time, and the anesthesiologists available. And typically those patients considered as a positive for COVID-19 till proven otherwise. And the first liner, of course, the anesthesiologist, especially doing general anesthesia, intubating, managing the airway, and also any procedures related to the patient care will be done by the anesthesiologist during that time. The use of PAPR and N95 was very essential and has been really planned very well. Most of the institution, they got this early, especially in the perioperative area, anesthesiologists and surgeons, they should have those because the infection risk is really high. Many challenges really did happen, like an early communication and planning and execution has to be done by the anesthesiologist to manage those critical patients who are really highly susceptible or suspected to be positive cases for infection. Then the airway management. Beyond the role of the anesthesiologist in the operating room, they typically move to a more advanced help in the airway management outside the operating room. New areas. They are really showing a sign and symptoms of a rapid deterioration of a COVID. They will really require a mechanical ventilation, and mechanical ventilation need an intubation, and those patients really need to be the most expert physician who are the anesthesiologists to do the early intervention. Of course, this will reduce the multiple attempt and also reducing the aerosol generating infection exposure. And that's why it's really a more burden on the anesthesiologist to lead this management of the airway in the whole institute or all hospitals. Most of the institutions, especially in Saudi Arabia, also in the Gulf or internationally, has been reported a lot of planning for the airway management. And as usual, some countries, they don't have the PPEs or N95, and this make it more even challenge outside the operating room. There is many modification in the routine intubation by avoiding bag mask ventilation and using videolaryngoscopy mainly to be away from the patient, and the risk of infection will be reduced. And the Saudi Anesthesia Society really developed a great practice guidelines early on and has been practiced by many institutions, and they really out and they follow the algorithm, which really give a clear, safe approach for the airway management. Then the intensive care unit anesthesiologist role was very clear. Overwhelming infection. If you see in Europe, the infection rate is almost 1,000 on a daily basis. All the hospitals are really full. They require some of them mechanical ventilation with a range of 2 to 10% of the patients, and all the ICU are full. Opening an operating room run by anesthesiologists was the most essential to overcome this cannot be really met without the help of anesthesiologists to run independently intensive care unit. And that was part of the important role for the anesthesiologist to really do. It was an extra effort, extra work, opening a new ICU run exclusively by the anesthesiologist. And really the most of the outcome study showed an excellent result. In fact, rapid extubation for those patients running or the patient in the ICU run by anesthesiologists. They are the most expert in early extubation if required, middle of the night. They have not afraid of doing that, and also early intervention if required, and early decision maker. And this is make a huge difference in our institution, and I'm sure most of the institution. The operating room and the recovery area has been used as an intensive care unit for mechanically ventilated patient, and difficulty typically when the crisis happen. Of course, not many area is available with a negative pressure, but the use of the HEPA filters and other precaution make those successful journey for our patients. The last, which is probably one of the most important things, is a rapid response team. Rapid response team is as you know, in a crisis situations, many hospitals develop a rapid response team like in disasters, any situation. But of the COVID was the most vulnerable disease during 2020, and of course, the challenges happen to all healthcare system, that there is a disaster, the healthcare have to be really leading this. And when it comes to an institution, the institution already has a physician to can this by their skills and leading this rapid response team, and this rapid thing will be done completely. Patient will require a resuscitation. They will be done by that, like in a code blue teams, but it's in an isolated area. So they're putting 20, 30 patients in one area, and that's will the rapid response team, they will be responsible for that, and they will have a great efforts to manage those patients. And as I mentioned, the team are led by anesthesiologists. and has been many reports in the literatures that those are very successful stories, as you know, limiting the personnel to 2 to 3 highly skilled, avoiding an exposure of the other health team members to such an infection. So this is a typical scenario of the most extra efforts. There is many things in the literature has been published, and if you see from China, from Europe, from North Americans, the role of anesthesiologists during the pandemic in China has been really reported very well and shown, and a great effort of the anesthesiologists, specifically all other healthcare workers during this pandemic. And if you see the other literature review also as the changing the future possibility and the practice of anesthesiologists as a perioperative physician, plus caring for outside the operating room, opening safe intensive care unit areas in case in the demand, and anesthesiologist-based intensive care. We could have just a few slides for literature review, and we will go from this is another one, critical care during corona crisis, reflection and the role of anesthesiologists in the pandemic. Again, the second one. I think I encourage all of you to review those, and we can share it with all of you, those type of cases and editorial report during the pandemic role of anesthesiologists. This is really a typical one of the best review article, which is the value of anesthesiologists in a COVID, a model for our future practice. Things has really probably will change. With that, I will really mention some few points that issue arising during such a pandemic. It was very exhausting, long working hours, potential for a burnout, and those are really essential for healthcare system. They deserve more as anesthesiologists. I will not go through more details. I think I will leave Professor Ahmad to talk about those really issues arising from the work during those pandemics and even before that, and hopefully we can reach to some recommendation that the higher authorities will be really help to eliminate such issues in the future. Thank you, Professor Ahmad.
Thank you, Dr. Muhammad. As Dr. Muhammad said, actually, it's as we can see, anesthesia practitioners, they are like everywhere in the hospital. They are in the covering ICU. They are in the OR doing. They are doing urgent surgery and emergency surgery. They are in recovery doing overflow from ICU. They are in the rapid response team. They are in the airway management team. All these issues, no doubt, made a huge load on anesthesia practitioners. That a concern of stress and burnout may raise, and there are like a lot of concern that physicians, especially the acute care physicians, or including anesthesia for sure, they are highly susceptible to stress and burnout during their practice. So it will not. It may involve all practitioners, including male, females, young, and older, experience with or less experience. But nobody is immune against such a concern. But we have to define or differentiate between stress and the burnout. Stress is when the individual's ability to cope with and deal with the demand is exceeded. And actually, in some time, such stress is highly needed in order just for the practitioner to improve his or her performance. In the other hand, the burnout is completely different. Is completely different story. It is a syndrome characterized by depersonalization with emotional exhaustion and loss of sense of achievement, and it is secondary to the continuous excessive stresses without time or space for recovery. Having said that, we have to know the exact um, difference, symptom signs that happened with the stress and burnout in order for us just to diagnose ourselves if things will happen, and in order just to make ourselves in a much better situation. In stress, we usually we feel over engaged, our emotions are overreactive, and it will give us a sense of urgency and hyperactivity, and it may lead to some of the anxiety disorders, and we may feel some physical abnormalities. In the other hand, the burnout is different, is disengagement completely. People are feeling blunted emotions. They are helpless and hopeless. They lose their motivation and ideals, and they are so emotional, and they will not proceed to any further reactions. Uh, of course, there are many reasons why stress and burnout may arise, especially in our specialty as anesthesia and physician. So a lack of control of work environment, this is very important issue, and we're going to talk about it. Strained professional relationships, work overload, unpredictability of the work, also the admin responsibility that we may do plus our clinical duties, teaching responsibilities, peer review, potential litigation that we are always feeling that maybe somebody will complain against us, disturbance of our sleep rhythm, conflict between our demand of the work and the home, of course, no doubt, personal and family illnesses, other social issues, including financial concerns. All these issues are reasons for stress and burnout. And there are more people, they are more susceptible, they are more have more risk to have such to develop such a syndrome or such a risk, including a younger age of group, that they are because they are less professional experience, so they have less time to develop effective strategy for dealing with occupational and stress. Also, the female are reporting that they have higher incidence of burnout comparing to the men. The social background of the person or the individual, it can be a risk factor. A social isolation in both work and home will increase the risk of burnout. The coping strategy, we mean by that they are either negative strategies or positive strategies. Positive strategies including doing exercises, meditation for sure, having a proper social network. These are protective against developing stress and burnout. In the other hand, negative, including the use of of alcohol and illicit substances, are also usually, especially in the Western population, associated with higher risk of burnout. Also, the personality feature of the individual having a high indicator of whether a patient will develop a stress or burnout easily or not. Individuals who are like stable and difficult to change, usually they are immune to develop such thing. In the other hand, unstable personality, usually they are easily to be stressed and usually easy to have a burnout. And also, and these are what I talked about was individuals risk factor, but we have also an organizational work-related risk factor that to develop such a risk, including work-life imbalance. So this is very important issue that spending more time at work, it will lead to less time for personal interest, family, and the time for recovery. Also lack of control. And this is what anesthesia and other acute care medicine they are facing. Inability to control our own time, because we cannot control our schedule, our assignment, the workload. It depends on the surgical list, and the assignment on it depends on something on somebody else. Lack of resources needed to perform satisfactory delivery also can contribute to the burnout, and this is very important issue because the weakness in clinical achievement usually associated with high risk of developing stress and burnout. People who are clinically competent, usually they are at more immune to develop such a risk, because they know themselves and they can prevent it. Also, the workplace and colleague culture and dysfunction. Also, these issues are very important. It can happen, including racism and inequality of work distribution, lead to such development of such syndrome, which is the burnout. Having said that, we should know what are the effects of such stress or such a burnout on us. For individual level, usually the stress and burnout, usually it may lead to an anxiety and psychiatric disorders. It may lead to a depression, absenteeism, substance abuse, obesity, and decline in working ability. It may lead also to some appearance of psychosomatic manifestation, non-cardiac chest pain, palpitation, shortness of breath, bowel upset, dizziness, headaches in form of tension headaches, and other all can appear during such a burnout. The individual about the patient themselves, usually the patient who are cared after a burned out and physician or stress physician, they have usually they express less satisfaction of performance of care. Also, they have increased risk of developing medical errors and litigation and court litigation. And for the institution, the effect of the stress and the burnout, usually the institution will they have to support or to replace a burned out physician, and this is no doubt an extra cost. Also, there are less time for a proper quantity working hours, and also usually they are disharmony and dysfunction between the healthcare team members, leading to more medical errors and side effect complication on the patient care. All these issues it can happen very easily if we did not diagnose ourselves or take care of ourselves. So how can we deal with such a burnout? There are like many ways to do it, and so the easiest ways is just to remember the 3 R's in burnout: recognition, reversal, and resilience. Talking about recognition, the recognition is because people should know themselves, and if there is any change from the normal, from the norm or from the routine behavior or personality, especially in such a level of professional level like physicians, they should know that they are at the edge of developing a stress or an over stress or a burnout. So they should recognize that, and they should seek help from the health expert, including either their directors or their chairman, or to the occupational health department in their institution. Also, the directors, chairman, and other administrators, they should take care of their employees, and they should know about whether they are to develop such burnout or stress, and they have to try to solve it as soon as possible before things gonna negatively affect the patient care. And also the institution themselves, they should build up an infrastructure to fight such development of burnout or stress. After the recognition, we have the reversal. And my next slide I will talk in detail about the reversal. And but before that, I will talk about resilience, which is a very important issue during it's protective before recognition and even after recognition. We should enjoy our time. We should enjoy that we are taking care of our patient. We should enjoy that we are successful in our career. We should enjoy that we are providing services to the others, and we should enjoy that we are physicians and we are in the top of the academic in our academic career. All this issue will make you resilient to develop such syndrome. We have to have the attitude of a proper communication with our colleagues, other junior, senior colleagues, but the paramedics, the non-physicians. We have to have a proper communication with all of these people, with all this staff, in order just to have very positive personality and attitude. And we have always to act in a positive attitude. We have to always think about something good that may happen after during that I'm taking care of such patient. These resilience are very important step in order just to make a proper life of your own working life. In other hand, how to reverse and how to prevent such a complication of your professional career. It is either at the personal level or at the environmental level. At the personal level, every one of us he should have some his own spiritual practices, including, it depends on himself, and he's the only one that he should tell himself what to do in the spiritual level to improve his life. Have to have proper exercises himself, and to have a proper dieting in order to have proper lifestyle. You have to have hobbies outside the work in order just to time for recovery after working hours. In the other hand, we should not forget about what the institution should do, what the departments should do. The department and the institution, they should recruit extra staff all the time. We should not let our staff feeling short, feeling stressed, feeling that they have to do more of the work. One person can do 2-3 work of 3 persons, like a superhuman physician. No, this is not right. Allowing adequate rest between the shift and the calls also, this is very important, especially for our trainees. Improving workplace communication between different parties, surgeon and anesthesia, anesthesia and nurses, front desk, all should have a proper communication. Also, we have to have a proper academic career counseling and training and credentialing in order just to feel people, push the people to feel more confident clinically and academically. Also to improve the laws and regulation in the hospital, also having healthcare, having occupational healthcare clinic, also in order just to diagnose and treat and counsel risk individual that may develop such syndrome. Um, all, the, all these issues, we should take care of it in order just not to develop a serious outcome of our very busy life, clinical life. These are some of the references and that it may help to read. And also I'm happy to send any one of you that he need these things. By this, we're gonna reach to the conclusion and highlight. And so I will invite Dr. Mohammed Al-Harbi to comment, please, on our SAS summary and highlight on our role in healthcare system.
Thank you, Prof. I think it's a great eye-opener. I just reassure you that during the recent studies, burnout anesthesiologist is not number one, not number 2 or 3. His one study is 4 and the other one is number 6. So there is other specialty. They do have high burnout and stress also in their life and their work. But it's a really eye-opener. We have to consider this in our chairman's division head to look on this and take care of their colleagues. So we will not take long. The recommendation is really, we must say that we are really proud of all of you. Anesthesiologists are the backbone of any healthcare facility. Very clear role during the pandemic, everywhere, nationally and internationally. Anesthesiologists are the most reliable and the most important part in any plan that any are or planning in the future. The expertise for the anesthesiologists in medical and surgical patients made them the best clinical during a crisis. Healthcare facility should reach into a very safe, effective, and cost-effective management of the patients. I think this is the most important thing that we're really highlighting. We're really proud of all of you to be anesthesiologists and continue your work. And Professor Ahmad, I think, has some also points, please.
Yeah, and thank you, Muhammad. And as we said, that we are at risk of to develop such stress and burnout syndrome. So we should take steps in order just to prevent developing such risk. Also, the healthcare facility, they should take steps, positive steps, in order just to reduce such risk. And this risk, we're gonna summarize it in to develop anesthesia team concept in the OR, in where that anesthesia team consists of a consultant plus an assistant. This assistant including a resident or a staff physician, in order to reduce the amount of stresses that we may face during patient care. Also, we have to have to develop plans for continuous professional development for different level in our career, as a consultant, as a junior, as a senior, as a resident, as a trainees. We have to have a proper plans for continuous professional development. Also, the institution, they have to limit the extended working hours and to implement working hours law similar to the other specialties, including emergency physicians, emergency medicine physicians, in order just to prevent anesthesia from overwork. And as we can know, when ER physicians, they finish the shift, they just do the handover and they just leave it to the other shift. On the other hand, in anesthesia, we may stay in our OR covering long surgery. It may be from 8 a.m. morning till 10 p.m. Evening. So who gonna make the difference in this working hours? So this is, we should have a steps in order to limit such working hours. And we have to have also enough manpower coverage reaching to the standard of the international institutions, one operating room for equal to 1.5 consultant, in order just to have to compensate for the vacations and for the sick leaves. And also we have to encourage, and we have to have some scale for proper financial compensation and incentive, like an overtime, and have a proper salary scale in order just to make people more satisfied and to work without fear of stress and burnout. And by this, I think we have reached to the end of our presentations, including our previous five sessions. And really, I want to thank all my colleagues, and also I want to thank for all the attendance for attending. Hopefully, and we added some positive and of benefit points to our attendees. I will leave the mic for Dr. Abdulaziz, and if to proceed, Dr. Abdulaziz. Dr. Abdulaziz. Okay, Dr. Abdulaziz, I think he is. Maybe there is a problem, a technical issue. I'm gonna stop now sharing.
I think we'd like to thank everybody for the questions. We have many questions regarding CME hours. It's 2 CME hours. Has been will be accredited for all registered and speakers. And there was a question regarding I will need from the panelist question to you. There is a question that emergency room, any patient suspected COVID, they will call anesthesiologist for a difficult airway. What shall we do? Dr. Daghestani.
Thank you, Mohammed. In fact, probably you already touched on that. And in many hospitals, the most expert airway intervention is the anesthesiologist. You know, in those patients, you want to minimize traumatizing the airway. At the same time, you want to minimize the trials for intubation in those patients. That's why I believe the anesthesiologist is the best person to do that. And I'm sure same in my place and many other places, we have formed a team that is called an acute intervention airway team, which consists of the on-call anesthesiologist and accompanied by a technician who is more familiar with airway tools. And this team is usually the person who responds to any call in ER. Those patients are usually kept in the negative pressure room. So by default, before entering into that room, you will be assigned the protective, personal protective equipment, devices, the tools and everything. And you proceed into that room. The aim and the target always is to minimize the aerosol generating maneuvers, at the same time minimize the intervention part and secure the airway as fast as possible. So I do acknowledge and I do admire all of our young colleagues and our senior colleagues who got involved in the care of those patients. I'm personally myself, I was involved in many patients. One of them was a very difficult, patient who was morbidly obese. His BMI was 65, and he had a standing, hypoxia, and we did an awake fiber optic patient on him. And this is just an example of your expertise employed into action.
And I agree with that totally. I think I agree with that, especially in such a situation. We need the most expert person to interfere with the patient. We should not leave it for the trials and errors. Yeah, no doubt. Also, I have a question, and I have just read it from the Q&A box. I will direct it to Dr. Abdullah Harbi. The question is, Abdullah, is it better to designate one anesthesia machine to be used exclusively for COVID-19 patient, either confirmed or suspected?
But before Dr. Ahmed, let me answer the question. I think we should increase the chance of exposure for people to intubate and not to wait to have a COVID epidemic where we don't have time to intubate all the hospital. So the expertise in ICU, the expertise in ER, the expertise have to improve. We've seen a lot of people who have zero basic background of how they don't know what the vocal cord look like. And accepting this responsibility to be done by the best people have unfair situation that, number one, you cannot cover. Number two, you have infection for all anesthesia departments, you cannot do anything. But I think we should readdress this topic and even make a conference. Airway is a shared sign, should be done by not only anesthesia, by most of specialty. Sorry, Dr. Abdullah Harbi, I know you allow me for this interruption, but both Harbi know I cannot stop. Go ahead.
That's all right. Thank you for Jamie. And I agree with regard to that. Part. I understand both perspectives. I'm commenting in the previous question because it's a very complex question, and it comes to me daily, I think, and I think most of the manager or the chief probably they face it. And there is no right answer, I would say. Yes, I think we have the duty to provide the best care to the patient, and we believe anesthesia, they have the best probably training. But again, how much resources that you have in the department to cover all these calls, because sometimes you'll find that the patient is actually not evaluated at all by any other specialty and was just labeled difficult and someone was just called in. So it's a matter of balance sometimes, actually, what is best for the department so it can function properly and help other patients, and what is probably in the best interest of that specific patient. So it's always hard, actually. And probably the best approach is readdressing this one and opening. And sometimes if we have a lot of, probably it's hard to say it's common, but I have seen it probably more than in the past that we are having a lot of specialty that actually they're trying to move away from managing the airway, although they are actually critical or they have training in airway like emergency or ICU. So I think it's something need to be really readdressed from both sides and reevaluated. With regard to the anesthesia machine, so I think the recommendations and probably most hospitals that during the peak of the pandemic, they assigned a negative room with the anesthesia machine and also even the video laryngoscopes. It's all in one room. So it's just to minimize the cross-infection or spreading infection. The problem so it was easy at that time. The problem now with most hospitals moving toward actually the post-endemic era and trying to expand. So we have noticed that some hospitals, they eliminated that negative room and they just kept it that if there is a suspected patient, then we have to take the precautions for that one and turn on HEPA filter. So I think if you have the resources, if you can allocate room, it will be advisable. From our side, I think that standard precautions and also having, if you have someone suspected, even if it's not the machine itself, the cleaning, sending the part of the ventilator to the CSSD after any suspected case. I think that's what I would advise.
Thank you. Abdulaziz, if you have. Okay. طيب, Dr. Muhammad, do you have anything you want to add?
I would like to thank everybody for this great meeting, and hopefully we can, to everybody, all the panelists, we will summarize those recommendations, and it will be really forwarded to the higher authorities. I think Saudi Safety Center, and also Majlis al-Daman al-Sahhi, also that will be included in the recommendation.
Again, yeah, thank you everybody, and as Muhammad said, we're gonna inshallah publish a recommendation out of this, which is gonna be the summary of our summary and highlights of our recommendation باذن ta'ala, to the higher authority in Ministry of Health and others.
I want to thank all of the people who is thinking out of the box this 2020 and 2021. Really, Anesthesia Society is different this year. Whatever changes you guys make to make all these participants come, more than 500 participants come to here at night, and second and third activity, really, inshallah, يضعوا ميزان حسناتكم. People need all this education. I don't think they're coming for the CME. They really hungry to hear from a society which is under the dark for a long time. Shedding the light on the society by such events and these things, we really encourage, and we hope it continue not every month, even every day. And thank you for all the people in SAS who is doing the best work, which we don't know them. But really, all the panel, I would like to thank them from Jeddah, from Riyadh, from Dammam, from everywhere in the kingdom. Tell them that what you do is really appreciated.
Okay, thank you, Dr. Nasser. And I also would like to thank everybody and for the attendees to attend. And inshallah, we'll see you soon in further educational conferences. Thank DrDawlatly for this conducting this meeting. Thank all the moderators for helping us, and inshallah we'll see you soon.
Okay, thank you everybody. Thank you. مع السلامة. شكرا جميعا.
Thank you everyone, and it's my pleasure being part of this gathering, and Prof. Ahmed and Dr. Muhammad, thank you very much for looking after the well-being of the anesthesiologists in the kingdom. Thank you very much, and we do appreciate that you do highlight those points very well, and we do appreciate that this consensus is going to go to the authorities in an official format. Thank you all.
Thank you.
Thank you. See you soon.
الله يحفظكم. مع السلامة.